The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between.
So we're taping our first episode for the year as we're stuck here at my dad's house in Potomac, Maryland. It's a snowstorm in D.C. For those of you who don't live in D.C., 2 inches of snow totally stops the city for the next 3 days. And we have somebody that we've been wanting to have on the podcast since we started the podcast because she's a dear friend of mine, a phenomenal pediatrician and even a greater leader. Dr. Sandy Chung is a distinguished pediatrician and healthcare leader with over 2 decades of experience. She's the CEO of Trusted Doctors, a prominent pediatric group in Virginia, Maryland, and District of Columbia, comprising over 300 clinicians. In addition to her role at Trusted Doctors, she is the medical director of informatics of the Pediatric Health Network at Children's National Hospital. She has held more than 30 state and national leadership positions, including president of the Virginia chapter of the American Academy of Pediatrics and founder of the and medical director of the Virginia Mental Health Access Program. Her leadership extends to her tenure as the national president of the American Academy of Pediatrics in 2023. During this time, amongst many other achievements, she guided pediatricians through unprecedented challenges, emphasizing innovation and passion for pediatric care. Dr. Chung's contributions have been recognized with multiple awards, including the Marjorie Dimes Lifetime Heroine Award and Modern Healthcare's 100 Most Influential People in Healthcare. Sandy, such a joy to see you. Thank you for coming on the podcast. We've been waiting for such a long time to see you on the podcast.
Well, thank you so much for having me here. I think it's been an amazing adventure over these last few years, and so I'm excited to have an opportunity to chat with you now. So
that's awesome. Sandy, we always start by asking people the same question. Why did you become a pediatrician?
Yeah, that's a great question. My story might be a little less traditional, but it's hard to say. You know, I think we all come from so many different backgrounds. My parents immigrated to this country from China, and when they got to this country, despite having master's degrees in mathematics and computer science, they didn't speak English well enough. And so they couldn't get professional jobs. And so my mom ended up sewing clothes in a factory, and my dad was a waiter in a restaurant. And then I was born. So I was born into essentially really quite poor circumstances. We lived in a trailer park. I was on Medicaid. I remember counting out food stamps to help buy groceries with my mom at the grocery store. And eventually they saved up enough money to start a Chinese restaurant. And so I grew up working in a Chinese restaurant. And so I had to do a project in the 4th grade about what I wanted to be when I grew up. And so I didn't know. There were no physicians in my family, so that wasn't a thing. My parents never took us to the doctor. If we needed something, we would go to the local urgent care, but that was only if something was falling off or you were bleeding a lot. We would go maybe to an urgent care. I got my shots at the health department. And so I was standing at the bus stop in the 4th grade. I was 9 years old. And I had to do this project, and I was sort of musing out loud. I'm like, I have to do something about what I want to be when I grow up, and I don't know what it should be. And the mother of one of my neighbors was my classmates, actually. The mom was standing there, and she said to me, Sandy, you should become a doctor. And I looked at her and I said, okay. But I didn't know what that was. And so she gave me she happened to be an OR nurse. And so she gave me the little head covers, that you wear over your hair in the OR, and shoe covers and a tongue depressor. And she even let me borrow her stethoscope. And at that point, I was going to become a doctor. And of course, when you say you're going to be a doctor, you get lots of positive reinforcement. So that started me down my journey. And luckily, it worked out. I was good at math and science and really enjoyed it, and found my calling, and that's how it began. And that's how I decided to become a doctor. And I love children, and so pediatrics became a very natural fit for me. And so that's how it worked out.
Wow. And now I don't think you realize how much working in Chinese restaurants like running a pediatric practice.
It's so true.
You
Yeah,
know,
I think that's so true.
I
Um,
think I think that every pediatrician should work bus tables at a restaurant to learn customer service and
exactly.
juggling, right?
That's
Because
right.
that's what
And you
we do
work.
most of the day.
That's right. And, my parents' restaurant was open for 47 years straight
Uh,
and only closed for half a day in 47 years.
Wow.
And that one day that they had to close, it was because there was a fire in the kitchen and the health department said they had to close. So my father decided he would just open up part of the restaurant just to serve drinks because he couldn't
Oh, wow.
stand the idea of not being open. But that need to really be there when people need you. We didn't have weekends, we didn't have holidays, we worked those days. And so I think some of that work ethic also rubbed off. And then the small business mentality for sure. That was very much like a pediatric practice.
Did they sell the restaurant or did one of the kids take it over? Or?
Oh no, we would not do that. So they would have loved it. Actually, I don't think they would have. They came to this country to give us a better opportunity, and the idea of us owning a restaurant because it's a hard life, and the idea of doing that really wasn't their plans for us, and so yeah, they ended up selling it in their 80s. It
Oh,
was
wow.
literally a mom and pop shop. My father was the cook in the back, and my mom was the waitress and cashier up front. And so they finally had to sell it just for many reasons. But yeah,
Oh, wow. Wow. So are you a good Chinese cook?
I am not.
Oh, man. I was looking forward to an invitation.
But I'm really good at eating Chinese food. I see.
So one of the reasons we wanted to have you on the podcast today was because I was talking to Sue Cressley, who I know is a real good friend of yours. And we were talking about CINs and IPAs and groups without walls. And she said, well, you should ask Sandy Chung. No one knows more about these things than Sandy. So I was wondering if I could pick your brain a little bit about all these different acronyms and their advantages and disadvantages and where you've found great success and where it didn't work. So let's start with the IPAs, because I remember the IPA that you and Russ Livy tried to start up with. I think back then was Fairfax Pediatrics. I don't know what they're called. Not Fairfax Pediatrics, Fairfax Family Practice. I don't know what they're called because they joined one system, and I don't know where they're at today. But what was that? What is an IPA, and what are the advantages and what are the disadvantages?
Yeah, I appreciate the question. And I thank Sue for thinking so highly of me and you as well. I certainly do not know all of the things about all of these things, but I've had quite a bit of experience with all the different acronyms through my career. In 2011, two pediatric practices, so Russ Libby's practice and my practice, Fairfax Pediatrics, we decided to join with two adult internal medicine groups and one large family practice to form what's called an IPA. And the IPA at that point was a CIN, so a clinically integrated network, where we all had different tax IDs, but we were going to work with insurance companies on something that was called value-based care. And that was now 14 years ago. And we knew something was coming, but it wasn't something that was very common at that point in time. And what we did is we came together and we figured out what we needed to do legally in order to work together on value-based care. And there were all sorts of new rules that were popping up at the time and new standards, which are commonplace now, but at the time were pretty groundbreaking, where practices could work together with an insurance company on these sort of add-on contracts where if we did a good job, we would get potentially shared savings, and then we would get a per member per month payment for meeting certain measures or doing care coordination. And so altogether, we formed this group called Health Connect IPA. Health Connect IPA still exists. And currently we have about 400 clinicians, adult and pediatric practices in that group. And we continue to do value-based care. We did programs with Medicare. We did that with commercial payers. We had a little bit of Medicaid. And I learned a lot back then. I learned how you needed to work with different groups and how we needed to share data. I have about now almost 20 years in health informatics experience. So did a lot of work around data sharing, and EMRs were still fairly new at that time, and groups were adopting EMRs much quicker with the whole meaningful use efforts that were happening back then. And so we were figuring out, how do we collect data? How do we share that information? How do we do quality work together? And that's the premise behind a clinically integrated network. They still exist today. I work with Children's National and their clinically integrated network. I work with another one from UVA and Children's Hospital King's Daughters, their clinically integrated network. And you can be in more than one of these, but per payer, you can only be in one contract. So for example, if you're working in an Aetna value-based agreement, you can only be in one. It can be with a different CIN than your United agreement or your Blue Cross Blue Shield agreement, but you can only be in one.
And so
per payer.
the IPA, that one didn't negotiate fee for service.
Fee for
contracts.
service. It did a little bit. And this varies a lot based on the market. So in some markets, so in California, for example, the little that I know about this, but the IPAs, they are very prominent and they negotiate the fee for service, or they are the fee for service. They may be fully at risk. But in other markets, so here in the Mid-Atlantic, a lot of the payers were not negotiating fee for service agreements unless you were a single tax ID. That has changed a little bit recently, but I think every market is different. So depending on where you're located, the rules may be different. What the payers are willing to do might be different. But I do think that it should be an awareness that all over the country, there are models where CINs or IPAs are negotiating fee-for-service agreements successfully for separate tax IDs that are working together in a clinically integrated way.
And so really, then the nomenclature is really not that important. An IPA and a CIN could look very much the same.
They can. IPAs sometimes will do other things other than just the value-based agreements or contract negotiations or clinical work. They may be buying groups. They may have other administrative support for practices. Yeah, but the lines have blurred quite a bit over the years.
And then I've been at the meetings for the children's CIN. Other than a big discount on the HR and these wonderful meetings that they put on, doesn't seem to me like, and maybe I'm just unaware of what all they're doing to integrate clinical data and to negotiate value-based contracts.
Yeah, they've actually been successful in negotiating value-based agreements with multiple payers, and they've negotiated fee-for-service agreements for a couple of them as well. And the data exchange part of it is really important and legally required, so that you can be doing quality work together, right? The premise of being able to do this together is that it's necessary in order to perform the work. So in order to perform the work of care coordination and sharing data and improving quality, for example, doing asthma QI projects together or mental health QI projects together, then it is necessary to fund the infrastructure behind that, which is where the per member per month and the shared savings and sometimes the fee-for-service contracts being increased is provided in order for a CIN to do all of that.
And now that CIN, you can be an ECW, PZC, or OP.
Anything.
Yeah. So you don't. It really doesn't matter. The difference is that the CINs, every practice maintains its own tax ID and its own corporate structure at that level.
That's correct. Okay. So as a practice, you're still doing all the things that you would normally do. You're a separate entity. The PHN, the Pediatric Health Network at Children's, that clinically integrated network has its own tax ID. So the contracts that are negotiated for value-based care are with that entity. And then as an independent practice, you sign on to it, essentially, as an amendment to your current agreement.
I saw recently a new contract for, I forget their name, but they're just coming to Virginia. They do adults and children. And they have an interesting contract where the share savings doesn't really seem to exist. And it's just, they give you $20 if you complete, more than 6 visits in the first 18 months, and then $20 for physical thereafter. And I think $100 for if you follow up a patient after discharge from the hospital, and $100 quarterly if you're doing the chronic disease management. So it seems like it's kind of like a CIN. They started in Arizona. It seemed a little too good to be true that there's no reporting of BMIs, vaccination rates. It's like, oh, just do the physical. We'll send you a check every quarter. But I like the idea. To me, that's better because I think no matter how sophisticated you get, except for, I don't think most of humanity understands, delayed gratification. We kind of like to have our dessert before we do the exercising. And so I think sometimes
there's definitely psychology. Yeah.
This episode is sponsored by our friends over at Freed AI Medical Scribes. Let's hear what they have to say. What if you could take the computer out of the physician-patient relationship? With Freed, you can. Freed is the AI medical scribe that listens, transcribes, and crafts perfect SOAP notes for you seamlessly. This isn't just another productivity tool. Freed is a life-altering solution for physicians, helping you regain the joy of practicing medicine. Freed frees you from the burden of documentation, so you can focus on what really matters, your patients. With Freed, the computer is no longer a barrier. It's a quiet assistant that works in the background, capturing every word of your patient interactions, accurately and quickly. The result, you're fully present in each visit, building stronger connections and offering more attentive care. And when the day is done, your notes are too, leaving you with more time to focus on yourself, your family, and your life outside of medicine. Freed is the solution thousands of physicians swear by to reclaim their passion for medicine.
I think some of these programs where they say, well, if you meet these expectations at the end of the year, we'll give you this and we'll give you that. People are like, oh, okay. And then, it kind of drops off the radar. And the end of the year comes and if you're not very intentional, you don't make the money. But if they're paying you every time, you get a little extra every time you do the work you're supposed to be doing, well, you see it and you know it.
Yeah, I think there's definitely a psychology behind how these different incentive programs are designed. So the kinds that you're describing where it's sort of a pay for performance, but at the time of service, has existed for multiple payers, multiple programs over the years. Dollar for dollar, it would be interesting to study to see if the return is the same. I don't believe it is, but it depends on whether or not you're successful in the other types of contracts, right? So if you're not successful in getting shared savings, and if your per member per month is at risk and you have to give it back, then the guaranteed, $20, $30, $40 up front is much better. But if you are in other kinds of programs where maybe that per member per month is guaranteed, but the shared savings isn't, then that's different. So all of this really, the devil's in the details and the amount of analytics behind it. It's not hard math. None of it's hard math, but you do have to take the time to do it to know which plan makes the most sense for your group.
And it's hard to get the data out of those EHRs, isn't it?
For sure. It's getting better though, but yes.
And also, how do I say this politely? Data is only meaningful if you are being accurate about recording the data.
Correct. Garbage in, garbage out, right?
Yes. So, I mean, if not, I'm not saying anyone does this, but I'm just going to say, for an instance, if your QIP is based on reporting BMIs, the easiest way to be 100% sure is put a normal BMI on every chart and report it as part of your claims. But that's garbage, because then you can't figure out what percentage of the population is actually overweight, obese, or underweight, and come up with an action plan to change it. But you'll get your money. You just don't have real data to do good, but you'll get your money. So that's one of the problems. I'm deathly opposed, like dying, deathly opposed to share savings contracts. Because if you understand, we just had this conversation this morning, every human being is different and their motivations are different. In pediatrics, just to make it a little bit worse, you got a mother, a father, and a grandmother sometimes. And they decide what the kid does or doesn't do. And we try to persuade people to do what we think is best for their child. But at the end of the day, it's not our child. And if the parents decide that they don't want to do this or that, it's their choice. And,
Yeah, I think what you're
affecting
saying
that
too.
affecting that human behavior isn't as easy as just me telling you, get the flu shot,
Yeah,
right?
for sure. I think there are multiple issues around shared savings model, the adult model, essentially. Even for adults, it's not ideal. But applying that to pediatrics, there's a fallacy there to say that, first of all, children are expensive and that there's money to save, right?
There
In
isn't.
order for shared savings to work, that has to exist. And that's not true. And so, are there a few things we could do? Absolutely. Reducing ER utilization, using generic drugs if that's cheaper, depending on the payer. But, so there are some things we could do. But for the most part, children who are in the hospital need to be in the hospital for a reason. We aren't keeping them there because it's an increased length of stay or whatever the case might be. If we're sending a child to the ER for a fever and they're 2 months old or 6 weeks old, they need to be there. It's not because it's a visit that shouldn't be in the ER. So the premise behind adult shared savings agreements doesn't work for pediatrics. And I'll give you a good example where during the pandemic, when kids were not getting sick because they were home, right? They weren't in school, they weren't sharing illnesses. The viral burden of disease went way down. And so to survive in our practices, but also to provide care, we did a lot of well visits, right? We did a ton of checkups. We did more checkups than in a year than maybe we had before. And certainly we were doing them at the time of year where normally we wouldn't have been, like it was March and April and all of that was happening. Well, in our shared savings agreement for that year, we didn't do well. And the reason why we didn't do well is because we saw more checkups and fewer sick visits. And checkups are just more expensive. They have vaccines, they have screening tests, they might have a sick visit attached to a well visit. So the costs went up. And so if you didn't do well on your shared savings, it was because you did more checkups. And so I said to the insurance companies when I was talking to them, I was like, did you want me to do fewer checkups? Is that what you really wanted me to do, to save money, do fewer preventative visits, do fewer vaccines? And they said no. And I said, well, then this is a pretty good example of why in pediatrics, if we do our job well, if we do more prevention, if we do the mental health visits, if we do the longer visits and we do the chronic care visits and we do the preventative visits, we're actually going to be more expensive. And so shared savings just doesn't work as a way to keep us sustainable. And they saw that. I do think that there's a lot of conversation we need to continue to have with our national payers and Medicaid, the different groups that are designing value-based agreements for peds, to say, instead, for pediatrics, we need to be investing in the visits. It may cost more in the short run, but in the long run, there's savings. There's savings to society. There's savings to other parts of the systems. Yeah. And that's always been our challenge in pediatrics, is to show that savings, which happens in the Department of Justice when kids don't go to jail or go to juvenile justice. It shows when later they become a healthy workforce, right? It shows in social services where, this wrong pocket phenomenon that happens. We just need to do a better job of showing what that actually is.
Well, the formula is simple, and I always use something as simple as polio vaccines, right? Polio vaccines are not, actually, they're not very expensive. They're like, I think, $20 a vaccine. So you get 3 in the first year of life, $60 plus the $100 for the well child exam. So you're spending $400. The problem is that there's no polio, so you're saving nothing. It's just an expense. So the word I like to use is impact. What is the impact of children being able to go to swimming pools in the summer without fear that they're going to end up paralyzed or dead? What is the impact that has on society? And it does have a financial number, because every child that's paralyzed or dies is one less productive member of society that doesn't pay taxes, doesn't raise a family, doesn't buy a home, doesn't buy a car. but it has impact in our social well-being. I just can't measure it with a dollar amount. But let's stop vaccinating for polio and have it come back to see how crazy we become. And that's a thing that the MBAs and the financial analysts can't wrap their heads around because they can't put a number to impact.
I think that the other industries, several other industries, actually do a really good job of that. Where, if you take someone who does analytics and financial analytics and economics, they are able to quantify that savings. You'll see it often in other things. If we do this, that'll save the country so many billions of dollars, right? Somebody did the math and figured it out. And you outlined a few things that if you can put dollar amounts behind and actually provide real numbers. It's really pediatricians and those who work in child health continuing to actually invest in doing that work. I think that we talk about it a lot. We talk about it as the right thing to do, to make sure that kids stay healthy. We know it's the right thing to do, but that's not a business argument, for the insurance companies or the large employers. So, thinking about how do you measure presenteeism when your employees come to work because their kids are happy and healthy and in school. I think that there is real actual work that can be done that we need to do so that we can prove our worth to whoever needs that information.
Yeah, because a simple economic formula that they use, this is how much we're spending on heart attacks. If we put people on statins, this is how much we save. That does not work in preventive medicine. So that we have to change our verbiage, our language, our way of looking at it. And my simple word, because I'm a simple person, is impact. What is the impact? Impact can take 30, 40 years for you to be able to see it, but the impact is there. And then you've been phenomenally successful. I mean, at so many things, but you've started a group without walls. And why is that different model there is everybody has to be under the same tax ID versus the CIN or the IPA? Why did you think there was a need for that in the area?
Yeah, I think that, again, it does depend on where you are locally and what happens in your market. But in our market, the ability for a CIN to be successful in supporting practices financially was very limited because it was limited to these value-based care agreements and not much more than that. Over the years, as I mentioned, in 2011, we started the IPA. Over the next decade to 2 decades, the adult medicine practices were peeling off. They were joining large, either health systems, private equity-backed firms. They were being bought out. They were doing different things that appealed to them. And the pediatricians were basically left behind a little bit. Not in a bad way. Those were not things that, as a practice, we were interested in doing. It's certainly a model that exists, and for some practices, it's the right thing to do. But for our practice, we wanted to stay independent. And so looking at that, as I was watching and learning from the adult medicine side, really seeing that this evolution of new models that could exist where practices could join together under a single tax ID, retain some autonomy in your day-to-day function and work, but still ultimately be a single tax ID and be a single entity, which then brings you leverage of all sorts for negotiating for savings, negotiating for agreements, providing clinical care together, being able to work on quality together. It was really just this wonderful multiplier where, for example, for billing, if our biller solved a problem for one practice, for one insurance, that biller could simultaneously solve that problem for all the practices at once, by making that one phone call to an insurance company to say, hey, this shouldn't be bundled. You should pay for it separately. And once they got that done, then it solved it for all the practices together. So that ability to sort of help each other, really, I think was really the driver behind what started the idea behind Trusted Doctors, which is the name of our supergroup. And there were others. I think there were already others in the country. So we were lucky to have some great folks to learn from.
But it has had phenomenal growth, right? It's not been around for that long, and you went from Fairfax Pediatrics to 300 clinicians in three jurisdictions.
Yeah.
That's phenomenal.
Yeah, we started in 2018. It was a collaboration between 3 peds groups. Eventually, only 2 decided to do it. And then with that, we were able to then have other groups continue to join us. And it's been phenomenal. We haven't had to market, it's a lot of it's been word of mouth. And it's been really great. We've grown very quickly. So in 6 years, we went from just our 2 practices to now we have 25 practices, and they span DC, Virginia, Maryland. Yeah.
Wow. And then again, I believe that you guys are EHR agnostic too.
We have 2 by choice. We could have more. The billing part gets more complicated the more you add, of course. So because we do centralized billing together.
And I don't understand that. That's like if I use OP, how does the computer know? Like is it just a data exchange? All puts it in one bucket and then it gets sorted out later?
Sort of, yeah. So if you think about it, when you are seeing a patient in your practice, and let's say one practice is on, one EMR and the other one's on the other, then you're seeing them the same way in your EMR system. And at the end of the day, you're going to finish off your note and you're going to lock it and send it. And it's going to go out through the first to the billing office to scrub it, make sure everything looks good. And then it's just going to go out through the clearinghouse to the insurance companies. Where the consolidation happens is the insurance companies, because you're under one tax ID, sees you as one entity. So the payments come back all together. Now, they're delineated by line item of who delivered the service. So we can see by NPI whose payment it belongs to, and by location and everything. And then it's a matter of posting the payment back to right EMR, right? Because you want the patient to get that credit for saying your insurance paid this much, now you owe us the rest, or whatever the write-offs are. And so that posting of payments is the part that gets complicated if you have multiple EMRs. Some of our software does it automatically, most of it actually. And so, but it does take quite a bit of IT connections and things to make that work, right?
Okay, so it's
the few where there's, yeah.
So it's automatic. So you don't have to have a person sorting it out.
So it works like a billing company might, so a billing company that services multiple practices. The difference is the payments come in together, so you have to separate them out.
Okay. And then the billing office, does it have coders? Do the coders do the coding before it goes out? Or is it the physician still clicking in the EHR and then scrubbing the claims?
Yeah, so the physician has to still do the first part. We may have coders on the back end to double check. Only certified coders, as you know, can change codes. So basically, we have some certified coders that help. As you get to a certain size, if the idea is to build a super group, I think when you get together, the first is just making it all work, and figuring out we're all employed by the same tax ID. So there's quite a bit of HR transition that happens there. And so once you get everything working, then the next step is to really optimize and to improve everything that we can improve without taking away autonomy, right? So looking at workflows, looking at billing practices, looking at coding practices, those are things we can do and be helpful together. It's just been lovely. It's been lovely being able to work together in a large group, share ideas. When there's a new code, we can all say, what are you doing with that code? Are you using it? Well, let's just test it and see what happens. Everybody else wait a minute while we try it and see what happens. Oh, look, it worked. Okay, everybody do it, and so like G2211 is a good example for that, like let's just try it and see what happens. But let's just try it in a few few locations first, make sure that it doesn't like fail the entire claim so that you lose all your money. So it's an opportunity to try things with each other, and it's been really fun.
And so then, the G2211 is a perfect example, right? It was a great idea. It was a lot of work was done by the American Academy of Family Practice to get this through Congress. And then, except for one national payer, most did not adopt it. And the one that did adopt it has now bundled it. And so what is your thought? Do you still put the G2211 there, even though it gets written off, because it's important to plant the flag on the territory?
Yeah, I think it's important to bill it as long as it's not causing you financial harm to bill it, because otherwise, if we go and advocate that it should be paid and the insurance company says, well, nobody's billing it, then there's no argument to be had, right? So if people are billing it, then we can say, hey, this should be paid. This is why. Here are the reasons why. Here's the business case for it. Then they will see that people are using it. So it is important to bill it if you're able to.
Okay. It doesn't bother me, but some people are like, well, I'll have more write-offs. Well, yeah. So, don't charge $500 for it,
Right.
You're not going to get paid for it, but you want to make sure that you're documented, that you're doing the work and that you should get paid for it. So you sit down in the negotiations, you say, we did all of this work and we never got paid for it. So now, what do you think? Do you have such a phenomenal experience as being a physician leader? What is the best way for a medical organization to be led? And I mean, personnel-wise. And my bias is that they need someone like you, a strong physician leader, and then a work wife or husband or whatever partner who is a very strong operationals person. They're different hats.
Yeah, I think it depends a little on the size of the group as far as what you need in leadership. I do think it's helpful to have someone who has experienced the issue to be in leadership, because there's nothing like being able to advocate for the amount of work it takes to help a child who is suicidal, and you've had to work with the parents separately, and you've had to call the school, and you've had to do this, that, and the other. If you've gone through that yourself, it's just a much more powerful advocacy story, if you will, to be able to say to a payer, this was hard, and this was really hard, and it took a long time. And if this was your child, you'd want me to spend that time. But in order for me to spend that time, I need to be paid appropriately, or I can't. Right. And if I can't, it's to the detriment of this child and their family. So, being able to have had that lived experience is really important. I feel like when you're trying to especially work on payment in particular, but all sorts of things, just being able to help lead that. Now, the flip side is that most of us didn't go to business school. Some of us have, but not everybody has. And so we weren't taught in medical school how to necessarily manage financials, or how to lead organizational change, or how to do human resources, or know HR law. There's a lot of education that's necessary to do that work, just like there is, to do our work. And so unless you go through some of that training, having a side person, your partner with you, be it an administrator, office manager, COO, whatever their name is, whatever their title is, having someone like that at your side is really important to be successful. And it's just because we don't have all the training. Now, if you have the training, fantastic, even that with that, you're only one person. And so you sometimes just need somebody else just to have enough bandwidth to do it.
Yeah, I think sometimes, I think this is so true of really great clinicians. They know the limit of their ability, so they know when to call the surgeon or the subspecialist. And I think leading big groups is the same thing, or even small groups. You got to understand what you're great at and what you need someone else to take care of, because one, you're not interested or you don't have the education. And if you're able to delegate, you can be very successful.
Yeah. The other piece of that is I think you should find it fun, and you should find joy in the work, because if you're doing it because nobody else will do it, that probably won't get you as far as if you're doing it because you really love it and you really enjoy it. So if you don't enjoy it, maybe find somebody who does, who can work with you. That can be helpful.
And then what is and why VMAP?
So VMAP is the Virginia Mental Health Access Program, and that is a statewide program that I founded. This was back in 2017. And so, and it's really to help pediatricians and family physicians, nurse practitioners, and PAs to manage mental health conditions for their patients. They're known as child psychiatry consult lines in some places. It's a pediatric mental health care access programs in some places. They're now actually in nearly every state and territory in the United States. So that's really exciting, in large part because of advocacy work that happened with AAP and others. So that's been really great. But back in 2017, it really started with a patient when I had a patient who was a 14-year-old young man, and he had bipolar disorder, and he was seeing a child psychiatrist, and a child psychiatrist had retired. And so that they called our practice needing help finding it. Well, they called and made an appointment with the psychiatrist. It was about 4 to 6 months later. So this is before the pandemic. There was already a waiting list. There was already a crisis going on. When we looked at his medications, he was on 5 different medicines. They were complicated ones that we don't normally prescribe. They were atypical antipsychotics, other things. So we weren't comfortable prescribing them. And also in Virginia at that time, pediatricians, if we prescribed them, Medicaid wouldn't pay for them. They would only pay for them if a psychiatrist prescribed them. Yeah. So we said, well, we can't refill them, but let us help you find another appointment sooner. So we called and called and called and called. And we got him an appointment with the child psychiatrist about 4 weeks later. So we thought we were in good shape. During that 4-week period, though, unfortunately, he ran out of his medicines. And when he ran out of his medicines, he had an exacerbation of his disease. And he got into a fight in a parking lot, actually near my office. And in that fight, he actually had a gun, and he shot and he killed somebody. Oh. So that 14-year-old ended up in juvenile justice, and that other man lost his life. And so to me, that was horribly tragic. There was so much that could have been different in our systems and the way we managed what was going on to prevent that from happening. And across the country, across our state, we had so many kids who were just waiting for care and could not get care. And at the same time, they were coming into our offices needing help. And so also some of that moral injury was there, trying to be able to help someone and not having the information, not having the resources, all of that. So I learned about these programs, these child psychiatry access lines, where Washington, D.C. had a program, Maryland had a program, and North Carolina had part of one, but Virginia didn't have one at all. I was about to become our state chapter AAP president. And so I thought, gosh, what a perfect opportunity to try to help create a program here. How do we make this work in Virginia? And I think also just having had the business background, being able to understand how do you start something up, operationalize it, finance it, all of that was really important too. And then just having a ton of partners, a ton of stakeholders. I've traveled around the state, met with different people, psychiatrists, mental health providers, health systems, insurance companies, legislators, patient advocates, all these individuals, and said, we need something like this. Can we create something? And luckily, people agreed. And at first, when we started VMAP, it was just volunteers. So we had no funding. And it was basically psychiatrists saying, hey, I'll answer the phone if people call. Some people were like, I'll teach a class, I'll teach about this anxiety and I'll teach about depression and so forth. And then there was this REACH program you may have heard of. So it's it's basically like a mini fellowship that you can take. It's a national program out of New York. It's from the REACH Institute, but it's basically a weekend-long training to learn more. Pediatricians can learn more how to do this work. And then it's several months of follow-up phone call, case-based learning sessions. And so we had some of our health systems starting to sponsor that. Inova sponsored it. CHKD sponsored them. And so we had a cohort of pediatricians that were starting to learn how to do this work, but they needed help because once you start doing this work, you very quickly can get out of your depth and need help. We need a consult. When you have a cardiac question, you can call and speak to the cardiologist on call and usually talk to somebody right away, and they can help you and figure out what to do with this child. That doesn't always work in psychiatry if you're not in an academic center, right? If there's no access, there's nobody to call. So the purpose behind VMAP is to create this statewide phone number so that anyone working in Virginia who's seeing a child can pick up the phone and speak to a child psychiatrist or a psychologist or a mental health provider within 30 minutes. And that exists today. We also have care navigation resources because we're not therapists and we know the families need ongoing care. They may need a psychiatrist ongoing, right? We're there to kind of help get things started, but eventually they need care. So we have care navigation resources to help families find care. all of this has over the years has grown. So now we have state funding, we have federal funding. It's been really fabulous. So much wonderful, wonderful support and amazing humans helping to make this work across the state. We've done over 23,000 hours of training at this point and trained over 1,500, 1,600 clinicians and continuing to grow that. We're working with emergency rooms, we're working with schools. We're also teaching primary care how to diagnose autism using a tool called the STAT. And then so that we can make the diagnosis and then get kids to ABA therapy or whatever therapy is appropriate sooner. So they don't have to wait to 18 months to see a DBP because as you know, there's a tremendous shortage of developmental behavioral pediatricians as well. So really exciting how we can use this model to continue to expand and help pediatricians do that important work. The follow-on to that, though, is that we need to make sure the payment's appropriate so that we can afford to do this work because all the visits are longer, they take more time, obviously. And so we're doing a lot of advocacy work right now to make that happen.
So it's a phenomenal program in many ways.
Thank you.
You've done incredible work in such a small amount of time. You've also added, I would call it a hotline for developmental pediatricians. So
That's right.
when you have that autistic child that's absolutely, just banging, running from one side of the examiner to the other, jumping on the stretcher, then banging the wall with their head, and then jumping off and banging the next wall. And you're like, I'm not going to give him Haldol. I'm not.
Right.
You call and they talk you down, from your own tree. I'm like a cat at the top of the tree on that. But they talk you down. They go, they're very patient. The money is not there, right? So it's a problem because particularly Medicaid doesn't pay for these care coordination codes a dime. And, sometimes you don't have time to talk to the developmental pediatrician or the psychiatrist the same day you see the patient. And so you're calling them, to talk to them first thing in the next day, once you've kind of gotten your head back straight and try to figure out what you need to do for the kid. And there's zero reimbursement for that from Medicaid in Virginia.
Yeah.
But that and the fact that you've been able to secure funding, so the REACH fellowship is quite expensive.
It is.
And for Virginia clinicians, it's all a scholarship.
Yeah. We're very fortunate that we have an administration, and it's been over 2 different administrations. It's very bipartisan, and we've had a great deal of support for VMAP. And they're so excited they want to have an adult version as well for the adult medicine doctors. We just actually started the VMAP for Moms Plus, where OBGYNs can call and pediatricians and family doctors when they're working with women who or people who are pregnant or have been recently pregnant and have been diagnosed with a mood disorder. That it's been really exciting to be able to expand it and hit the needed funding to make it work.
It's an incredible program that you set up.
Thank you.
I'm in awe of what you've done. And particularly what I find, the helpline is incredible, but you may or may not need to use it. I don't know. Sometimes you do, sometimes you don't. But I think that from my perspective, the secret sauce is the ECHO programs, where you meet as a group and there's a child psychiatrist and there's a pediatrician that is very much a champion in child health. And people present cases and you kind of do morbidity, mortality rounds on it. And you try to figure out, what would be the best course for that one child. Not only does it help you learn different disease states or processes, but it also starts building your confidence as to that you're not doing harm. I presented a case, and I don't mind saying on the air, I don't know what's wrong with the kid. I really don't. And the parents know I don't know what's wrong with the kid, but they're very happy because they brought the kid when they were 4 years old and he hadn't slept a single night in 4 years. And they were ready to get divorced. And neither one wanted to take care of the kid. It was incredibly terrible. And I just put him on quantity and the kid sleeps. Now we have other problems. And I presented the case and, you know, the psychiatrist said, well, Herb, what do you want to get out of this? And I said, well, I just want for you to tell me I'm not a quack. Really, it's very simple. I feel like I'm skating in such thin ice because I don't have a diagnosis and I don't have an MRI to prove my theory and I don't have a blood test to prove my theory. So I'm just hoping I'm doing the best and I have no idea when I'm going to be able to take this kid off of quantity until he sleeps or if I should ever do it. And she said, no, you're doing a wonderful job. You just got to keep with the family and wait and see what happens as he develops. But I can't tell you what the diagnosis is. Time will tell you. And I think that is such a valuable thing because it reassured me that I was doing the best because I'm not a child psychiatrist. I am not a child developmental specialist. Most of my career has been hospitalist, urgent care, emergency medicine. And I really felt that I was way out of my league and nowhere to send this kid. And for that, I can't thank you enough because the child has benefited. And I can't imagine how many thousands of kids across Virginia have benefited from your work, and the impact that you have had on those children is unbelievable.
Well, thank you. And thanks for sharing that story. I mean, it's such a wonderful example of how personal this is for us. When we're as pediatricians, we get so involved in people's lives, and it's such an honor and a blessing, but it's a lot of pressure. It's a
It is.
lot. And in order for us to do the best job we want, we want to do our best, but having that support is so important. And yeah, and you're giving me too much credit. It was certainly, I was a part of the beginning, of course, but there's so many wonderful human beings that actually make it work. So I'm
Absolutely.
very grateful to everyone who works on this. It's been
And so my follow-up question to that is, do you think the ECHO program, because it's the same problem, we have a crisis of primary care, but we also have a crisis of things like endocrinologists. And we have, as we did with mental health, and it's gotten worse, but now we have overweight children, obese children, children with metabolic syndrome, 10-year-olds who are pre-diabetics, children with type 2 diabetes. And to a large extent, it is a problem of lack of payment. So the endocrinologist and the pediatric endocrinologist is one of the few specialties that make less than the general pediatrician. And so they don't have the bandwidth to see all these patients. So is an ECHO program for these metabolic disorders a way to, one, build up workforce capacity, two, decrease burnout in our profession, because now you're part of a community, you're supported. And three, a true collaborative model where you can give the patient the best that you can afford to give them.
Yeah, I think the Project Echo model is not new, right? That was founded years and years ago out of New Mexico, I believe, where an adult physician who was helping those who were in rural communities to handle conditions where they couldn't access a specialist, right? And so the Project Echo model itself is very flexible. It's very possible to use for nearly everything. There does come the question of how much can we put on our primary care folks, right? And so we are certainly able to do lots of things to a degree, but we have a limited amount of time. And how do you design this? And the mental health work was also by necessity, that patients were showing up at our doors and there was just no place to refer them, no place to send them other than emergency rooms potentially. But I think that part of the need for the mental health access program was just the demand from ourselves saying, we need this and we need some help. please. So as we think about other disease states, you mentioned obesity, nutrition, metabolic syndrome, diabetes, all of that's critically important. Is the ECHO model the first part? It is a tool. It is a way to learn more information. But is it something people are demanding that they need more information about today? And I don't know the answer to that. You've asked me about this before, and I think, yes, if you have a champion, if there's a demand, if there's a supply of folks who want to do the teaching, who want to do the consulting, then there's that piece of it. The infrastructure itself is not, it's
Not there.
Yeah, it's not there. But it can be created if there's funding. All of those sort of real world operational problems can be solved for. I think, though, making sure that there's a demand for the information is step one.
Yeah, it's just every practice is so different. I live in Leesburg. Your office is in Fairfax. The patients in Fairfax depend, like in Centerville, a lot of Korean patients, right? You go over to Manassas, a lot of Spanish speaking. It's the same region. The clinic I help is in Dumfries. It's mostly non-white, mostly on Medicaid, lots of immigrants. So my experience helping that practice is mental health, obesity, and pre-diabetics or type 2 diabetics is what's in the exam room every day and is not being addressed. And there's no resources. Because I can't send, there's kids in that practice that are 10 years old that are 200 pounds. And they already have sleep apnea. They already have a hemoglobin A1C that's out of control. They're already hypertensive. And you can't send every one of those to a pediatric endocrinologist. You can't. They just don't have the appointments.
Yeah, no,
so I don't know what you do.
That's a good question. I think that when we're thinking about nutrition specifically, there is a lot, and I guess in mental health too, that there's just a lot around about culture in the community that leads to dietary habits, right? And so there's the question about sometimes it's poverty, sometimes it's just the lifestyle, sometimes it's safety. If you can't go outside and play, what do you do? So it's a complicated issue, but you're right. I mean, we need to do something there.
And sometimes it's genetics and culture, right?
Yep.
So South Asians, they have a much higher rate of type 2 diabetes than the Caucasians. They also eat a lot of NAM and they eat rice with every meal. Right. But the Chinese eat noodles and rice with every meal and they don't tend to gain weight. And do they eat less? Do they eat portions that are smaller? Is it genetic? They have higher metabolisms, so it's a complicated nut to crack because you got the genes, your dietary habits, and what you said, the environment.
Yeah, sure. And it's generalizations, right? Because I think within being Chinese, I can say this, but within the Chinese culture, there's different body types, there's different capability, all of those things. So I think it's an understanding that the individual piece. Now, are there things like education that could be better? Oh, absolutely. Are there things, that we can think about systemically, so looking at food in schools, and there's been a lot of work and advocacy in that space. When we're working with WIC programs, making sure that the food that the infants and children and toddlers, under age 5 are getting is healthy and that their moms are healthy. For the food SNAP programs, making sure that those are covering fresh fruits and vegetables, right? And all of that advocacy work continues to happen and is really important. But your question is really, how do you help us? How do you help the pediatricians who are seeing these patients every day? It feels very unsatisfying, perhaps, what we're currently doing. At food insecurity is another space where I'm spending more time now on the work that I'm doing, where we are screening for food insecurity largely to start with because insurance companies are making it part of their value-based programs, right? So we're screening, and at the end of the day, if you identify that a family is food insecure, right now, a lot of us, I don't know what you're doing, but a lot of us are just handing out lists of food banks, maybe giving a QR code to find help or Aunt Bertha or whatever the program's called in your communities, which is important and it's good to do, but just feels a little unsatisfying, because the family may not go to seek those resources and then nothing in their lives has changed. And so how do we change this and make that better for them? And so it is starting.
It's very difficult, but I think I go back to the people that studied ACEs, and they keep telling you over and over again is you may not be able to change poverty, nor are you expected to change poverty from the exam room, but you're staying there available for that child that's in poverty may make the whole difference for that child's life. And I think with metabolic disease is the same thing. I may not be able to change your genes, your food insecurity, your dietary habits at home, but if I can welcome you over and over again, I may have an impact in your life. And I may not be able to have an impact on 80% of the patients, but if I can help 2 out of 10, I feel like I've done some good. And so some of it is perspective, changing our own perspective.
That's right.
Of, we don't need to win 8 times out of 10. Winning 2 or 3 out of 10 is great. And that's difficult to swallow because as doctors, we want to win every single time, and we should, we can't accept death as everybody dies. So, what's the difference, right? So we have to have this, we want to win every time. We want to keep our patients healthy and alive. So we're running out of time, but I want to ask you a question. I'm going to have to ask you to come back, but because we haven't even touched AI and how that can be used to multiply our impact. But what do you think is the future of our specialty with all the headwinds that we have?
Yeah, I think there will always need to be a need for people who specialize in child health. The healthcare of the child is uniquely different than the healthcare of an adult. So I think as a specialty, we will be fine. There are certainly all sorts of issues around payment, around people being interested in choosing professions in pediatrics, including our subspecialties. And so there's a lot of advocacy work that needs to happen to ensure that there are enough people to take care of the kids of the future. What I find really interesting is that pediatrics specifically is very population health oriented. It's very advocacy oriented as well. We're advocating that families eat better, that they raise their children to be the healthiest that they can possibly be. So there's so much advocacy work that happens in pediatrics. I do feel like this next generation is very focused on not everyone, but some of them are focused on social justice and on improving things, looking at how we can make things better. And if you want to do that, pediatrics is the way to go, So I am hopeful. I'm hopeful for the future of our profession, but certainly know there's a lot of work to do.
I'm more concerned about access. I don't think with the way we're financing healthcare for children through Medicaid, that there can be access to all kids to a pediatrician, which should be what we say, just like we want every child to have access to elementary, middle school, and high school without doing the wallet biopsy of their parents' wallet. And unless Medicaid pays or we find a different funding solution for child health, we're not going to attract the brightest and the best into the profession, and every community won't have access to a pediatrician. And to me, that really gives me heartache. The goal should be every child in every community should have access. May not even be a pediatrician, maybe a nurse practitioner, that has done extra work in pediatrics because the community is too small to sustain anything else, but they should all have equal access. And that would be my hope for the profession.
Yeah,
And
I couldn't agree more. So,
that you've done tremendous amount of work in the role, both in the chapter and at the national level. And I don't know why you took that job at the national level. It seems like a terrible job to me. But other than the traveling to see other pediatricians, which I always love to do, the errors that you took. But I have to, from the bottom of my heart, thank you for putting yourself out there, for, spending 3 years on the road, and for still having a smile, still picking up the phone, and still talking to us, and still believing that we can make a difference if we stick together. Thank you for all the things you've done, Sandy. You've been a colleague, a great friend, and someone that I've admired since I hated your calling system when I was at Prince William Hospital. For those who don't know, Sandy was one of the first persons to adopt a automated answering phone system in her practice. And when you're in the nursery trying to tell her that you're going to discharge one of her babies so they can follow up, there was like 5 buttons to push. And I cursed every button I pushed until I got to your nurse to say, well, Sandy needs to see this kid tomorrow. There's nothing wrong. Here's his discharge weight. Mom's knows. She's got an appointment. You just make sure that's in the books. But it took 5 different numbers till I got to someone. But it's been
only 3 buttons now, Herb. So.
Oh, wow. Okay. I don't do that work anymore, so it doesn't annoy me.
Thank you so much for having me, Herb. It's been a pleasure, and thanks for all that you do. Appreciate it.
Thank you. Thank you, Sandy. Have a great day.
All right, you too. Bye-bye.
Bye.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.